Thank you, Hetal, for the invitation to be here. And again, echoing, this is a terrific symposium and really well covering all aspects of care. But today I'm privileged to talk with Gil, and we're going to focus on new and emerging anti-cytokine therapy for IBD. You've heard a lot about it over the course of the day, and we're going to focus on several aspects directly. The target is to really focus on what's new and evolving and the current status, if you would, as to what we use to treat patients that have Crohn's and ulcerative colitis. And we're going to contrast and compare some of the agents we have, discuss the clinical relevance, mechanisms, how they might play a role in different things, and then a focus. You've heard a lot about the IL-23s, and these are very commonly used, so we're going to focus on that to a high degree. There's relevant financial relationships that we have, and these are for myself and Gil, and Dr. Melmed was introduced previously, and I as well. Julie Messick was helpful in the slide creation, and we appreciate her help with this. The disclosures are listed here for myself and Gil, and this is accredited as well for 1 CME, so please scan it in. You have it before you on a piece of paper to gain credit. And it's 1 CME credit. And the disclaimer, which is standard. So we're grateful as well for the sponsorship that Johnson & Johnson has given for this symposium. And what I'll do now is to initiate discussion. So understanding cytokine pathways in IBD, and there's a whole myriad of different cytokines you've heard about, a soup of these, and you know which ones are important. But it's important to recognize that the gastrointestinal tract has about 70 to 80% of the body's immune cells. And this is important because this is where we want the reaction to be. The mucosal immune system is very finely tuned. There's dependent upon the food antigens that we eat, the other bacterial antigens. The microbiome is certainly an area that's very relevant in the GI tract itself. And these all finally regulate how people do with regards to their mucosal immune response and the inflammation that's present in the bowel itself. The overall occurrence of inflammatory bowel disease comes about in the genetically susceptible individual in the right environment, given the overall mucosal inflammation is normally there as a routine, but it's an accentuated response, if you would, and this leads to inflammation, ulceration. In Crohn's, we see stricture formation, and obviously we want to avoid that in the complications, fistula, abscesses, malignancies, and we want to lessen and attenuate the inflammation in an effort to better treat our patients and improve their quality of life while improving the overall function of their bowels. We see different cytokines that are involved in the intestinal inflammation. We've seen small molecule cytokines, and if you look here, you can see the different ones that look familiar and interactions that they have amongst each other. TNF, interleukin 12-23, JAK inhibitors play a role, the dendritic cells, the macrophages, finely tuned. In the bottom, you see the vasculature. On the top, you see the intestinal lumen. And it's a translocation of bacterial cell wall products and other things that come across that stimulate the inflammation and, quote, leaky gut. In other words, the ability of these to get across the gastrointestinal tract has gained popularity in the lay press, but also in the medical press. So it's an effort to attenuate the inflammation, keep patients in a state of well-being that we try to do. Interleukin 23 is a significant driver of Th17 cells directly, and these can lead to difficulty with the GI tract when they're overexpressed. Looking back historically, we see there are certain pro-inflammatory cytokines that are increased in the intestinal mucosa of patients with IBD. TNF and IL-23 are the ones we'll focus on. Interferon gamma has also been overexpressed, and a host of others directly, but this is one of the historical things that we've looked at directly. So to get your CME credit, you have to remember the years everything was approved. And this is not really, but this is a slide I put together many years ago, and I've updated it since, and I've included it. On the top is those that are FDA approved for Crohn's, and on the bottom are approved for ulcerative colitis. These are the years they came about. Remember, infliximab was 1998 August that it gained regulatory approval, and since then, we've got a lot of different molecules. There's 6 different mechanisms whereby we have molecules available to treat patients that have inflammatory bowel disease. We also have the biosimilars that have come into play: infliximab, adalimumab, ustekinumab biosimilars. We now have 8 different biosimilars for ustekinumab alone. So these make it cost beneficial, I guess, for the payers, less so for the patients, but prices of the actual agents have come down, as we've seen as well. So let's start on the IL-23s. So we have mechanism of action for ustekinumab is inhibiting the P40 component of the IL-12-23 complex. P40 is found on IL-12 and IL-23, and hence it's a bispecific molecule. It's the first bispecific that we had that inhibits IL-12 and 23 in an effort to treat patients, where it gained regulatory approval first for Crohn's and for ulcerative colitis. Realizing that was important, the question is, what if we just inhibit the IL-23? And hence guselkumab, mirikizumab, risankizumab came about. The P19 component of the IL-23 receptor is the area that's inhibited, leading to attenuation of the actual inflammation as a result of elevation of IL-23. Now, guselkumab is an agent that not only binds to the P19, but it's also a CD64, which is another area that's inhibited directly. The issue is, does this translate into clinically better overall inhibition of IL-23? And in humans, we don't know that yet. In animal models, it's suggestive. So this is enticing to say it differentiates itself somewhat. But again, we'd like to see this translate into human models. So these are the different agents we'll discuss today: guselkumab, mirikizumab, and risankizumab. And each of them is in a different circle, as you can see outlined there. And these are all the phase 3 trials that led to registration. So if you want to picture this and then go back and look up the trials, this is the way to do it, to really get an idea of what trials led to regulatory approval for each agent. But we'll talk about the compilation of these, or the assimilation of comparators, if you would, and whether it's appropriate or not to do so. It's done routinely. So what I'll do is to do that here. And Anita talked about network meta-analyses, and these are things that are critiqued in a big way. Some people say these are appropriate to use, others say not. And the way you can think about it is, if a trial has initially been done where they look at only those who respond and then go on and look at those subsequently for the maintenance phase, and then you have a trial that treats straight through that doesn't do that, how does one compare? Well, it makes it difficult. And there's many other scenarios where the critique is such. And in writing the guidelines for the ACG for Crohn's disease, we felt it was inappropriate to include randomized responders and those straight through, and only looked at a, quote, hierarchical suggestion based upon those that were comparative effectiveness trials. And we'll talk about those. Anita touched upon those directly. Whereas the AGA in the Clinical Practice Committee, which I served as chair of in the past, had decided otherwise. And they said, let's look at these and use network meta-analyses as the way to go ahead and to do so. And I would argue that it's perhaps a good hypothesis generator, not necessarily actual evidence to say this should be the standard of practice in all guidelines that we talk about. But that's controversy, and we can talk about that later if need be. But if you look here, you can see the different agents that are looked at. Ustekinumab on the left, and this is looking at ulcerative colitis induction trials on the left and maintenance trials. And the delta, if you look at that, a lower delta is something that is not as good. You want a higher delta because that's the number needed to treat. So a delta of 30 is about a number needed to treat of 3 to gain benefit in 1. A delta of 10 is a number needed to treat of 10 to gain benefit in 1. So if you look at that and you say, what's the most efficient way to treat a patient? You think that has the delta from placebo that's actually the higher number will do better. There's problems with clinical trials as well. Minorities are not well represented in the trials, and other criteria per se are not necessarily what you see in the office. Asher Kornbluth did a nice study with Tina High years ago, and they looked and they found that about 30% of patients they saw in the office would be eligible for clinical trials. So take that with a grain of salt, but this is what we have today, and this is a comparator that we have available. But the reality is, if you look, you can see a better magnitude on those on the right, and the more recent data for the P19 antagonists. And looking at this directly, anti-TNF non-responders, IL-23 is significantly increased. So those that have looked at individual trials and looked at subsequent treatments, for example, you treat a patient with initial therapy with an anti-TNF, should you go on and use vedolizumab? Well, the data from the primary trial suggests it's no more effective than placebo. The same thing has occurred with an anti-TNF going to another agent, unless it's an IL-23 or a small molecule. So upadacitinib has benefit, mirikizumab does have benefit, risankizumab has benefit, and guselkumab has benefit in an individual that has had a prior biologic. And clinically, that's important because that's in clinical practice. Vedolizumab didn't show any benefit for those with small bowel disease. So again, you have to pick and choose those individuals. Upadacitinib, less beneficial with small bowel disease, more so colonic when you do the post hoc analyses. But remember, these are not primary endpoints in the trials, they're post hoc. So we don't know if they fit in clinical practice, and real world evidence suggests these populations may do okay. But I bring this up because this is a key thing that we think of when we look at trials directly. Was it the first agent, a naive patient, or a prior failure? Those that have prior exposure do less well in general than those that are bio-naives. So you always want to pick your first drug and choose it well, and think of the individual patient. Do they have extraintestinal manifestations that you're trying to treat? Someone with pyoderma, you want to think of an anti-TNF, or upadacitinib works in that scenario as well. Think of what you're treating, not just the luminal disease. Are they going to conceive? One might be less aggressive in using a JAK inhibitor, and someone who's going to conceive in the next 3-6 months they want to. You might say, hey, let me get you on something first that works, then stay in remission 6 months. But these are things that come into the equation when trying to decide. So looking at these clinical remission rates in the ulcerative colitis trials, you can see there's clearly benefit, and the drug they're looking at is placebo. Here, superiority over placebo. But again, bio-naive does better than bio-exposed, but the IL-23s are better than superior than placebo still. So again, good choice to consider in a patient population that has been bio-exposed. Endoscopic remission rates as well. These are important to look at. Ustekinumab and the IL-23s. And again, the NNTs, you can see the bio-naive does better than the prior biologic-exposed therapy. So very important clinically when trying to think of treating a patient directly, are they resistant? Now, none of these trials have patients that have been exposed to like 4 or 5 biologics. Usually 3 is a limitation in the trial inclusion criteria. So it's hard to say what we do in that scenario. But again, this is where we think, should we use combination therapy when they failed many agents? Because you really want the patient to get in remission. We realize there's a better outcome, less surgery, less overall morbidity, less visualization if you're in a state of remission. So again, clinical remission rates in the pivotal clinical trials with Crohn's using the IL-12/23, ustekinumab, and the IL-23 inhibitors directly. And you can see across the spectrum, one of the best always consistently is guselkumab that we see for the network meta-analyses that Anita had pointed out directly. Not to say the other agents don't work, but again, it may come down to insurance. What does insurance cover directly? The other thing is, how does a patient want to get things? Some patients say, I don't want to give myself an injection. And with risankizumab, there's the on-body applicator, so it's not really an injection per se. It's putting some plastic on your abdomen, on your thigh. It makes it easier for the patients. Versus guselkumab is sub-Q induction and sub-Q maintenance, where the others are IV induction and sub-Q maintenance. So these are the factors that come to play when contemplating appropriate interventions. The pivotal trials with ustekinumab and IL-23. So clinical remission at week 8, you can see on the left, the bio-naive, the bio-failures. Once again, bio-naive does better in the magnitude, but they're very close in that scenario. So how about ustekinumab versus these agents? Well, you heard from Dr. Afzali before that in the trial that looked at ustekinumab versus risankizumab, it was open label. And other trials that have looked mirikizumab as well as guselkumab were randomized, placebo-controlled. So neither the patient nor the observer knew what the outcome would be. With the risankizumab, there was blinded endoscopy, centralized scoring. So that's something that's blinded and you can't take away. But both CDAI remission and endoscopy did well at the end with that population with risankizumab. If you look at the mirikizumab alone as well, you'll see that CDAI did not improve or did improve more so than those that were treated with the ustekinumab, but the endoscopy score was not. Whereas with guselkumab, endoscopy was superior, but the CDAI did not achieve less than 150 remission. So each has the pluses and the minuses. The reality is I think all are effective and they're used in clinical practice based on my experience, and you'll hear from Gil soon as well directly. But it's something to contemplate, and each one has its pluses and its minuses. But, you know, again, it comes down to clinical practice. None of these had looked at dose escalation, which we often do in clinical practice, which is, quote, off-label, but it is something to contemplate as well. So the overview, when you look at ustekinumab, mirikizumab, risankizumab, and guselkumab, there's different formulations, different antibodies directed against, and routes of administration, sub-Q, but the on-body applicator versus the sub-Q induction and maintenance, and guselkumab really is a differentiator with regards to these. The dosing schedules are in the package inserts you can pull out and read, but they're relatively convenient and easy to give. It makes it simple, so it's not a daily or an every other day, and its patient convenience is certainly there when we look at the dosing schedules for the IL-23s that we have. In addition, we have adverse events, and that's the beauty of the IL-23s. There's no black box warning for malignancy or infection in any of these agents directly. So their safety profile is at the top of the pyramid when we look at safety. That's along with vedolizumab as well as at that level directly. So it makes it easier. That's not to say you can't have complications. And in the SOLAR trial with ustekinumab, there was a higher rate of squamous cell carcinomas in those patients that had psoriasis. But again, psoriasis is itself a risk for having that directly. So I tell patients that it hasn't been shown that there is an accentuated risk, but there probably is some small risk directly for infectious complications and also malignancy that has yet to be demonstrated. Remember, the lymphoma risk in the general population is 2 in 10,000 patient years of follow-up per lymphoma. So you take 5,000 patients, 2-year study, to get lymphoma in the general population. With infliximab, there's a question of, is it about a twofold to fourfold? So if you look at that, it's still very uncommon. In a clinical practice, probably not going to see a lymphoma in general, but in registries, long-term registries, this was not identified. The TREAT registry, we had no higher risk. The Lemaitre study was a population study that looked at claims bases. Now, there's problems with that. So the issue is we don't know if there is truly a risk, but we say there is because there's not great studies that have looked long-term. And that's the data we're left with. So the safety pyramid I alluded to, this is something I think that makes an important contribution to choosing specific agents when you're seeing a patient. What are their comorbid conditions? Do they have congestive heart failure, class 3 or 4, New York Heart Association? If so, an anti-TNF's out of the equation. Do they have prior melanoma? You know, these are things, again, if so, then one would contemplate using vedolizumab. An IL-23 antagonist might be in the equation at that point in time. So looking at the individual patient and prognosticating, and there's factors on the right that have been included in an effort to better help you say, what are the factors that are involved with creating, quote, a safer use of a medical therapy for a population at hand? So in perspective, we look at the IL-23s. They are deemed to be safe. They have low immunogenicity. You heard that from Dr. Afzali. The numbers are very low, and that's the beauty. One can actually start therapy and stop therapy and have a very low chance of immunogenicity. Now, with the anti-TNFs, we don't advocate doing that, and it's combo therapy using methotrexate in combination with an anti-TNF. In other words, you try to prevent the immunogenicity because you lose a substantial amount of benefit over a course of a year, and this is not needed with these directly. The issue is we can't do therapeutic drug monitoring effectively with these directly. Risankizumab, I know the Mayo, there is a test one can order there, but on the website it says we don't know what to do, how to interpret it. There is data from ECHO that was presented that suggests one can use that, and we know that if you have a positive antibody and a level of 0, that's a bad thing. With ustekinumab, we have better data, but with mirikizumab and guselkumab, the data is not yet available, and it's not able to be measured as far as I know. So these were things that helped us with the anti-TNFs. And therapeutic drug monitoring is not something that we typically believe is necessary in this population. I would argue just dose escalate if you have a loss of response, and it's more cost-effective and appropriate for patients because it's easier to get that than not to. They're bioavailable. They work in patients that are biofailures that have responded to other agents and then lost their response. They also work on extraintestinal manifestations directly, and they seem superior to ustekinumab based upon the data we have, given the caveats that were discussed. So there are limitations as well, which we sort of alluded to, but hopefully this puts in perspective the use of the IL-23s from the basic standpoint. What I'm going to do now is turn it over to Dr. Melmed, and he'll focus on clinical practice and use of the IL-23s.
Thanks, Gary. So really, this is a continuation of Dr. Lichtenstein's comments. And now to sort of frame what we've talked about with the IL-23s as a class and how we think about some very important clinical questions. So one question that we often get is, when would you use an IL-23 first line for ulcerative colitis? And why are we focusing so much on IL-23s, as Gary alluded to? I mean, the safety profile, the efficacy profile, even the dosing profile has advantages over drugs that have come out previously. And so when we think about first line therapy for ulcerative colitis, we'll talk about initially, we'll focus on UC, and then we'll talk about Crohn's. Here are the AGA guidelines from 2024 for ulcerative colitis. Very similar to what Dr. Afzali showed us about the AGA guidelines for Crohn's disease. the AGA guidelines for ulcerative colitis also did something very novel. We have not seen this before in any guidelines in IBD, and that's actually helping us to think about the relative positioning of one therapy versus another therapy and putting them in some kind of order, right? There's all these therapies out there. How do we know which one to use and when? And so the AGA has started to take an approach to sort of put these in some kind of hierarchical order. They have those that they recommend, and then there are those that they suggest. So among those that they recommend are listed in the middle column there: infliximab, golimumab, vedolizumab, tofacitinib, et cetera, And then you have those that they suggest, which include adalimumab, mirikizumab, and filgotinib, which is not even a drug we use in the United States anymore. So the AGA guidelines are basically telling us, when can we use an IL-23 for ulcerative colitis? Well, we can use it right off the bat. We can and we should. This is based on what we already just heard in terms of safety, in terms of efficacy. These would be a very appropriate treatment for moderate to severely active ulcerative colitis, and certainly consistent with the AGA guidelines. Okay, well, if you're going to go with the drug, which one should you go with? Well, we have a higher efficacy medication box, and we have an intermediate efficacy medication box. And then we have the lower efficacy medication box. So obviously you want to reach for the medication with the higher efficacy, as long as you're not really giving up on safety or some other considerations, when you can. And that includes essentially our IL-23s with ustekinumab is listed in the intermediate efficacy, as well as some of our anti-TNFs, and then lower efficacy in the box there for first-line therapy would be adalimumab. On the right side of the screen, we have patients who've previously been on a biologic drug, then particularly an anti-TNF drug, then what would the next most effective or most appropriate choice be? And then again, the AGA here buckets these as sort of higher, intermediate, and lower efficacy. And we can see in the higher efficacy medications, we have ustekinumab, among the drugs that we're talking about here now, the IL-12, 23, and 23s. In the intermediates, we have our 3 IL-23s, and in the lower, we have adalimumab, vedolizumab, ozanimod, and etrasimod. So this is what the AGA put out in 2024. And I think Gary has already alluded to, and Dr. Afzali alluded to as well earlier. This is based on this hierarchical evidence-based guideline is based on a methodology called network meta-analysis. And I just want to, for a second, just explain what is a network meta-analysis and why are we sort of beating up on it? Because it's not really an opportunity to directly compare drug A to drug B, which would be ideal in a head-to-head trial to say, well, therefore, drug A is better than drug B, so we should position drug A ahead of drug B. What a network meta-analysis does, recognizing that we don't have head-to-head trials against all of the many medications we have available. So what a network meta-analysis does is it takes a trial, compares drug A to drug B, and another trial that compares drug B to drug C. And by statistical manipulation, you can say, well, the patients who got drug B in this trial are similar to the patients who got drug B in this trial, so therefore we can compare A to C, right? So we can sort of connect all the dots through the common patient populations that received a particular treatment. The most common treatment that patients receive in an IBD trial is placebo. So many of these are connected through the placebos, and we know. And the criticism is that we know that not every trial has the same eligibility criteria. Not every trial has the same trial design, as Gary mentioned. Not every trial has the same endpoints. They don't even measure endpoints at the same time points. And so that's why we're beating up on network meta-analyses, because these guidelines are based on what those network meta-analyses give us, recognizing they're using network meta-analysis because that's all we've got. We don't have head-to-head trials for most of these comparisons. So what we have are these NMAs, these network meta-analyses. But I just want to point out why we think that network meta-analysis methodology may not be the best way for us to think about truly hierarchical thinking when it comes to picking one drug off the shelf versus another one. Here are some key concepts when it comes to ulcerative colitis that I just want to highlight. I'm not going to read all of them, but I want to just highlight a few. And number one is, this comes, and when you're making the decision with a patient, right? You've got ulcerative colitis. You've determined you need an advanced therapy. How do we select which treatment you're going to use? The first point on the screen is, unfortunately, we don't yet have validated biomarkers that can help us determine which drug to use. Hopefully they're coming, and there are some in development and in late-stage clinical trials, but we don't yet have that validated biomarker. So unfortunately, we don't have that. But what we do therefore have is a lot of choice and a lot of options. And that next thing on the list here in the ACG guidelines is really important if it comes down to battling an insurance company, which unfortunately we all know too well about. And that is now in a guideline, enshrined in the ACG guideline, is that patients should have all medical options available as recommended by their doctor and their healthcare team. And this is something we can now put in our communications to insurance companies that, well, they say what the guidelines say, the guidelines don't say. Well, the guidelines now say that patients should have all medical treatment options available according to their healthcare team. Third-party payers and requirements for step therapy should not come between the patient and their healthcare team when making decisions about treatment for their ulcerative colitis. A third point here is that patients tend to have the best response with their first advanced therapy. Patients tend to have their best response with their first advanced therapy, so we really want to get it right as best we can in making the decision that the patients, you're picking something that's going to be appropriate for the patient, that's effective for what they have, that is administered with a frequency or a mechanism that they will stick to. If they don't like injections, maybe pick a non-injectable. If they want an oral option, think about what oral options we have, but pick something because they're likely to do the best with that first thing, first advanced therapy that they get to. I think that the point I want to skip to now is when it comes to anti-TNF therapy for ulcerative colitis. We talk about anti-TNF therapy as a class, but when it comes to ulcerative colitis, our guideline is now telling us we shouldn't think about anti-TNF therapy as a class. We need to think about anti-TNF therapy as a drug, and that drug is infliximab. That really is the drug that seems to have the most traction when it comes to where it's positioned among all the other drugs and among all the other anti-TNFs, and also in terms of our thinking that certainly in the patients with the more severe ulcerative colitis, infliximab really is the drug that we would reach for. And not the other available anti-TNFs. And so this is also a key point here in the ulcerative colitis guideline. Finally, the last point I want to make on this slide is that when we think about risk, we talk about lots of potential risk, potential side effects. It's also important to remember the likelihood of those side effects and put those in the context of the discussion with the patient. As you mentioned before in the discussion about vaccines, it's the same here. There's no risk-free option when it comes to our decision-making around treatments for patients with IBD. There's no risk-free option. Every drug has risks, but untreated disease also has risks. And so we're trying to find that balance. But when it comes to risk, and patients who are particularly at higher risk, they may be immune suppressed for other reasons. They may be older, they may have comorbidities, they may have polypharmacy. So when we think about risks for medications, the IL-23s, the IL-12/23, and vedolizumab have no boxed warnings, unlike the anti-TNFs and the JAK inhibitors. And so when we think about risk-averse patients or trying to find the most favorable safety profile, I don't want to use the word safest, right? But the most favorable safety profile, it's going to be vedolizumab or our IL-12/23 or IL-23s, because those don't have those special box warnings that we need to think about for the other medication classes. Next question to address is, when would you use an IL-23 inhibitor first line for Crohn's disease? So we just talked about ulcerative colitis. How would we think about it in Crohn's disease? And in Crohn's disease, it is a little bit different, not a lot different, but a little bit different. And here again, the AGA took the same approach as they did with ulcerative colitis. So they use that network meta-analysis to compare all the different trials that we have and try to put these drugs into buckets of what we would recommend or what would we suggest in terms of treatment. Now we've decided you need an advanced therapy. We recommend these, we suggest these, certainly over no therapy. And all of our IL-23s, as well as IL-12/23, ustekinumab, are in our recommended bucket. In our suggested bucket are going to be certolizumab, pegol, and vedolizumab. Those would be suggested over no treatment, but not recommended. And now when it comes to thinking about higher efficacy versus lower efficacy, again, we see a very similar inclusion of all of our IL-12/23 and 23 medications that we've been discussing in that higher efficacy bucket as first-line therapy. So to answer the question, when would it be appropriate to use an IL-23 as first-line therapy for Crohn's disease? We see here the AGA living guideline is telling us that all of our IL-23s would be appropriate as first-line therapy in a higher efficacy medication bucket. And for patients who've previously been exposed to an anti-TNF, our IL-23s are in the either higher efficacy bucket or intermediate efficacy bucket, again, with certolizumab and vedolizumab being in the lower efficacy bucket. Again, with the same caveats that we talked about earlier with that network meta-analysis, I think it's really hard to sometimes split hairs and say one drug truly should be considered higher versus intermediate based on that methodology, but this is what's now in the AGA living guideline. By the way, it's called, another novelty about the AGA guideline is that it's called a living guideline, unlike our prior guidelines, which would get updated once every several years. This is now what's called a living guideline with the intent, at least, to update this guideline every 6 months as new evidence comes out. And so that's a tall order that they've set up for themselves. We'll see if they're able to stick to that. But really, I think this is what we need. I mean, things are changing so fast. As I mentioned earlier, we've had 9 therapies approved for IBD in the last 2 years with 4 guidelines that have come out. So we really see this field so rapidly changing, and having a guideline update once every 5 years is not going to work, right? We need to have more updated guidelines and more updated guidance for how to use these drugs. And so this is what the AGA has set out for themselves, to have an update every 6 months. I think that means we'd be due now, right, Gary, for updates for both Crohn's and UC. This slide has already been shown by Anita, so I just want to show it very briefly. The updated ACG guidelines for Crohn's disease. We talked about the AGA, now this is the ACG. So both AGA and ACG published a guideline for Crohn's disease in the last year. Gary was the leading author, and certainly defer to Gary for questions that may come up around how these guidelines were developed. But basically what you're seeing here on the bottom half of the screen is everything we basically talked about with respect to our opportunity to use advanced therapies for our patients for both induction and maintenance. And this is different than the AGA guideline. The AGA guideline gave us hierarchy. Here, there's no hierarchy. Here, we're basically saying, these are the medication options that you have available, and here's all the reasons why you might use one or the other in that comment section. I just want to highlight one point about induction and maintenance. This is kind of historically an arbitrary distinction. We don't see this in some of our other immune-mediated diseases. We don't see induction and maintenance in rheumatoid arthritis, for example. So, this induction and maintenance with IBD is really intended for us to recognize that we need more upfront to get our IBD patients into remission or into response before we can back off a little bit on the drug. And that's why we see higher doses of virtually all of our therapies upfront, and then we back off to almost a preventive strategy. So we're really trying to put out that fire and then prevent it from coming back. And I think it's an important concept when we talk to patients about our dosing for these drugs, that they understand that when we're pivoting over to maintenance, we're really taking a preventive strategy because you're already well by then. And it's also important to therefore keep in mind and keep in touch with our patients as we start them on new therapies to ensure that they truly are responding before we let our foot off the pedal in that induction framework, because sometimes patients may not have been appropriately induced, and it may not be appropriate to right away go to maintenance therapy. Maybe they need to be switching therapies instead. This question came up from the audience earlier. Thank you for preempting that. Would you combine IL-23 inhibitors with other advanced therapies? But this is a little bit different than your question. Your question was, when do you combine therapies? Here, specifically IL-23s. And I want to point out here that I think IL-23s are an excellent choice when it comes to thinking about combinations. When I think about combinations, I think about safety and efficacy. Here, with IL-23s, we have a drug that packs a big punch with both. We've got a very favorable safety and very favorable efficacy. And so an IL-23 is an excellent choice if you want to pair it with a drug, perhaps that's very potent, but perhaps has a less favorable safety profile, like let's say a JAK inhibitor. That would be a great combination because you're using 2 very effective drugs, IL-23s having that real excellent safety profile, and then we get another very potent drug, even though we may have some safety considerations. I probably would not consider an anti-TNF, by the way, with a JAK inhibitor because of their safety considerations, but an IL-23, as the question frames here, would be an excellent choice to pair as a advanced therapy. And there is data on this. We alluded to it a little bit in the Q&A, but here's the actual data. This is data from the Vega trial. The Vega trial was combination therapy with an IL-23, guselkumab, and an anti-TNF, golimumab, in patients with ulcerative colitis that were essentially naive to both. And what we see here, and by the way, really, if we take these patients who are on the more naive side, on the less severe side, and treating them with combo therapy, we see all the way on the left side of the screen, 83% of patients are in clinical response at 12 weeks. 83%. Where do we see numbers like that? I mean, that's like, you know, we're talking about 8 out of 10 patients started on this combo were responding so early. And by week 38, still 70% of patients with 44% of patients in clinical remission. So these are spectacular efficacy numbers that we really haven't seen with monotherapy drugs. And by combining them, we are seeing these much better outcomes when it comes to efficacy. And that efficacy was better than either one of these drugs alone. And so we have now phase 3 Duet CD and Duet UC. Some of you might be participating in those trials that hopefully we'll be seeing data from soon in larger programs for future, who knows what this landscape is going to look like. But I think that many of us are very excited about the promise of combination therapy being able to deliver even better efficacy, breakthrough efficacy from what we can see with monotherapy. What about IL-23 inhibitors in a patient who has waning response to ustekinumab? Gary, when you showed your slide, you said we have 6 mechanisms. I don't know if anyone caught that. We have 6 mechanisms. And if you counted them on the screen, you distinguish the IL-12/23 mechanism from the IL-23 mechanism. Are those really 2 different mechanisms? I don't know, right? Both of them block IL-23. It's just that one of them also blocks another pathway, IL-12. And I think this is a question that many of us have been asking. Is this in the same family or is this in a different family? And if it's in a different family, then maybe we can think about the answer to this question being, yes, we should be able to use IL-23s in a patient who's losing response to an IL-12/23. Or if they're the same, then maybe we should be moving on to something totally different. So what does the data show? Unfortunately, most of the clinical trials, 5 out of the 6 indications, right? We have 3 drugs, each for Crohn's and UC, didn't include ustekinumab failures in their clinical trial programs. Only one did. Risankizumab for Crohn's did. And did actually show that in the ustekinumab exposed patients, risankizumab did actually work for those ustekinumab failure patients, similar to those that weren't ustekinumab exposed. And we also now have real-world data that shows that risankizumab is effective in Crohn's disease in patients with ustekinumab failure. You can see on the left side of the screen, those are the primary non-response to ustekinumab, had about a 40% steroid-free clinical remission at week 12 when they started risankizumab. And those with lots of response to ustekinumab had an even higher rate of response, of 57%. So it doesn't matter whether they were a primary non-responder to ustekinumab or whether they were a secondary non-responder to ustekinumab, meaning they had response, but they lost that response over time to ustekinumab. It is appropriate. I just want to emphasize that again. It is appropriate. I would agree with Gary the way you put that up on the screen. These would be, I think of them, even though they both block IL-23, I would think of them as separate classes. And just because somebody didn't respond to ustekinumab does not mean that they won't respond to IL-23. And it would be entirely appropriate to use an IL-23 in a patient, either from a non-response or even a loss of response to that prior drug. And this is data that we also showed previously, but I just want to highlight one other thing here. We see here in the sequence trial comparing ustekinumab and risankizumab, and Gary also showed us, and Anita did as well, some of the other IL-23s against ustekinumab. Here in the sequence trial, this was specifically an anti-TNF failure population. This is specifically an anti-TNF failure population, which is often how we think about when many of us are still using anti-TNFs first. Many of us are required to use anti-TNFs first based on an insurance plan requirement. And so this study really was geared to address that question. In an anti-TNF exposed patient, what is the likelihood of response to risankizumab versus ustekinumab? And for all of the endpoints that were set out at the beginning of this trial, all of those endpoints were met, suggesting that risankizumab is superior in every aspect or non-inferior in that 6-month window that they looked at. And so the question really was, would you use it in a ustekinumab failure? This is not really a ustekinumab failure study, but this data tells us that in anti-TNF failure, the next drug we probably should reach for should be an IL-23, not an IL-12/23. And so I want to end off with this slide, which is the slide that Anita started with, and really to sort of bring us back full circle to how we think about drugs in IBD. We're in a great time in IBD now that we have all of these new therapies that are available to us with better safety, with better efficacy, with better convenience for patients. We now have Q8 dosing intervals for sub-Q therapies, which we are able to offer to our patients, as well as more oral options. And so how do we think about bringing this all together in a decision with a patient? We think about the disease, we think about the patient, we think about the drug efficacy, and we think about the safety, and we have to bring that all together. If there's one thing that I would point out, and I'm not going to go through everything on the screen because we talked about them in prior talks, but if there's one thing that I would say, in my opinion, is the most important consideration, and it's something that Anita had alluded to in showing us data from the profile study, which was that early study in Crohn's disease, patients who were 2 weeks after diagnosis were treated with an anti-TNF drug and had response rates of 80% compared to 15% in those that waited. The most important consideration, in my opinion, is treat early. And it doesn't matter which drug you reach for. Pick any drug, but treat earlier. I think this paradigm of treating early is truly the best way we're going to make a dent in changing the natural progression and the complication rates we're still seeing in our patients with Crohn's and in ulcerative colitis. The proportion of patients who are needing surgery is still very significant for both of these conditions. And so this concept of treating early, here we have early versus late. The earlier we treat in Crohn's disease, the better. The drugs that we have today are effective. They're safe. They have very favorable profiles for both, and they're now designed in a way to optimize our patients' adherence to taking them effectively. Thank you very much.